Hi, Lila. Thank you for joining. I'm going to give everybody a couple more minutes, as I always do, to just join the feed, and I will encourage everybody for now, please say hi and let us know who you are and where you guys are from. So we would love to know kind of location and names so that we can respond. And of course, throughout, as always, we will ask you guys to post questions that you have live. All right. So why don't we go ahead? Hi, Jellybean. Good to see you. Why don't we go ahead and get started? And then we will, of course, allow continued discussion. And I'll encourage everybody, please keep saying hi throughout. Today, we are joined by Dr. Jason Spielman. Jason and I have had a long-standing relationship in the OCD world. And so we are so excited that he is here joining us to really share his expertise, his insight, and clinical knowledge that he has learned, observed, and continues to learn throughout the years. He's the clinical director of the Anxiety and OCD Treatment Center of Florida, and for 20 years, he's treated individuals with OCD, autism spectrum disorders, anxiety disorders, BDD, PANS, PANDAS, ADHD, you name it. He incorporates evidence-based care and techniques into all of the treatment that he provides. And this includes treatment for children, adolescents, adults, and individuals, groups, and all sorts of settings. Jason has extensive background in intensive treatment options, including residential care, intensive outpatient, and outpatient as well, and really specializes in so many different intervention modalities, including ERP, ACT, which is acceptance and commitment therapy, mindfulness, CBT, CBIT, and DBT, and then, of course, MI. What I want us to do today is we're going to spend some time talking a little bit about the basics of the treatment interventions that we often talk about. I think sometimes we jump into acronyms like ERP or DBT and people don't know what we're saying. So we'll certainly address that. And then we really want to focus on today in particular what intensive treatment looks like and what people can expect when they receive a higher level of care than traditional outpatient. And then, of course, we want to talk about what would make you a candidate. So what would make someone choose a more intensive option versus a less intensive option, and when are these types of treatments necessary or not necessary. Of course, as always, I would encourage everybody to post comments and questions that you have in the toolbar so that as we are talking and describing our background and experience, we'll make sure to address any questions that you all have. Hi, Amber. So good to see so many people. Tamara, lots of people. So we have individuals from India, from the Netherlands, from Florida, from Texas, across the globe. So we're excited that everyone's joined. And most importantly, Jason, so excited to have you here today, and thank you for joining us.
Thank you. Look, that was such a lovely welcome. I really appreciate it. And I didn't know I had that many things, to talk about. That's really nice. But thank you so much for having me on. And I'm so excited to be able to talk with you and be able to talk about some of the different options that you just mentioned and be able to hopefully help and share with some people who are sort of joining us for part of their day.
Absolutely. Well, let's hop right in. So I think it's important for us to start. Let's kind of lay the groundwork of what we're even talking about. And so why don't we start with, if you don't mind, just giving a brief description of OCD and ERP and really just kind of what ERP can look like in the different forms of treatment. So what treatment's available and what's the difference between like outpatient or say inpatient treatment?
Sure, that's a long question or a long answer. So I'll try to summarize, and we can break it apart and sort of unpack that a little bit more if we need to. But I think it really depends on the person, and it a lot of the time boils down to, I think, symptom severity overall, and also willingness. And I think a lot of the different live streams you've had guests on. I think most recently Dr. Brandt, I think it is, who talked a lot about where a person's at and different methods, even the Bergen method more recently, in terms of like, how do I know how much therapy I'll need? What will I need? Where do I start and what would I do? But I think overall, one of the first and most important things is recognizing, hey, that there's some type of issue. There's some type of problem that's going on. I'm not really sure entirely sometimes what it is. And, research actually shows that people who have OCD, it takes upwards of 7 years or more before they initially have an issue and that they finally see and find proper types of treatment. And I think that estimate could be conservative, actually. I think it might be a little higher than that. But I think OCD in itself, obviously, from a lot of the people who know, is having different obsessions or thoughts that we have in our mind that we get sort of a lot of the time ruminate over or stuck on, and they go over and over in our minds. And then a lot of the time, typically compulsions, which are the actions that we take, things that we do over and over again, a lot of the time to seek comfort in some of the obsessions. And sometimes we just have compulsions that we do over and over in a repetitive way. So typical forms, like probably has been talked about many times, of a type of cognitive behavioral therapy is called exposure response prevention or exposure ritual prevention. Depends on sort of where you're from and what you look at. But a lot of the times it has to do with being able to do something that goes against what's comfortable for you. You know, in the typical mindset of I have an urge to wash my hands, one of the goals we'd have with that is actually to move towards having your hands be dirty, feel dirty, the thought of it being dirty, or actually touching something that you feel is uncomfortable or dirty, and being able to sit with that discomfort and being able to have that last for a certain while of time, all while not giving into the urge to clean, to wash, and to fix the hands that are dirty and to make them sort of feel right again.
Absolutely. And when we think about ERP, I think it's important that we talk about the ways people can get ERP. And for some people, they struggle with what type of care do I need? And I guess when you were speaking, one of the things that really I realized is that, I think oftentimes people go to someone to get a psychological assessment to try to understand what's going on. And I think that they're, as an advocate, right, wearing that hat, that is really the first step to recovery, is being able to acknowledge that something's going on, that I need to get appropriate support and I need to consider treatment. But simultaneously, we see so many times where people go to someone and they're not getting the proper diagnosis. And this is where you talked about that 7-year gap, right? So the 7-year gap, it's like, okay, well, how then does somebody know if they're getting properly diagnosed? But more importantly, like, what would be indicative for them to know if like we're with the right person, if that makes sense? So we get that question all the time through Peace of Mind, where people will say, I've been going to this provider for this amount of time, I'm not getting better, this is what we're doing. Like, at what point do people say, let me get a second assessment or a second opinion?
Sure. I think that going through either the Peace of Mind Foundation or IOCDF, there's a lot of good people who are listed on there. I mean, looking at their background and their training, if they're certified through the BTTI, if they've had history of training people, how many years have they been working on that? I think one of the first and foremost things are they using specific skills and tools that are specific to OCD? I had one person who I started seeing about a week and a half ago, and they've been in treatment for 7 years. I said, okay, what was your Y-box score? Can you give me that? And they had no idea what a Y-box was or a Psy-box or any of those things, which is the Yale-Brown Obsessive Compulsive Rating Scale, and sort of like our gold standard of how we get a baseline of symptom severity, what your symptoms are, understanding how to make a hierarchy and things like that. So I think there's basic lingo and tools and things like that you would expect within OCD treatment at the bare minimum, let alone there's lots of other opportunities for success with lots of different spaces, which I know we're going to talk about in a little bit in terms of intensive treatment programs and what they should entail and what those really should look like. And some that work really well and others that, hey, that might not be the best idea in terms of what you do.
Yeah. And I think, one of the critical things, and I can't even describe how many times patients have thanked me when I've done an assessment with them, but I've also told them like, this isn't the right fit, and I think that's also a really important thing for us to just have in the back of our mind, which is that it's our job as providers to recommend what's in the best interest of our clients. And even if a client presented to me with clear OCD, if I was seeing them on an outpatient basis and that was the only level of care I had, but I knew they needed a higher level of care, it's my duty to let them know that and to really make a clear referral for what I would recommend versus, seeing them if I didn't think I was going to be able to be successful. And now sometimes you don't learn that until a few sessions in, right? Sometimes you might say, well, let's give it a try and let's see what happens. But let's know that like our treatment is continued assessment. And to me, that's usually really good indication as well of a good provider, right? Somebody who day one, they're using appropriate language. So they're talking about ERP. They know what the Y box is. They're talking about hierarchy development and habituation and words that we see commonly used in the OCD world, but also their willingness to refer out. And to me, I think it's interesting. One of my biggest struggles as an advocate is like, why are mental health clinicians not always bound by these like ethical requirements, right? Just like you said, we see this all the time where people say, I've been working with a provider for 5, 10 years, 15 years, and they've never done ERP. And you're thinking like, how is this okay when we have a proven treatment that works really well for OCD? And you're seeing people continue to see other individuals. So do you have any advice on just like quick ways besides, you did mention the BTTI, which if for those of you who don't know, if you go to iocdf.org and you look at their provider search, they have a section that says find help, and then you put in your zip code and providers in your area will pop up who may specialize in OCD. It's still your job as an individual to advocate for yourself and to make sure that this person's appropriately trained. And so often one of the indicators for us is it will say BTTI certified, which means that they've gone through this layer of a 3-day training that the International OCD Foundation really provides and hosts. And so my question to you would be, what from the beginning, besides the language, when people are just looking for a provider, what should they be looking for, and what typically might indicate this is somebody who has the background versus someone who doesn't?
I think you look for people, well, I think first and foremost, somebody that you can relate to. I mean, I think that the connection with a person is really important, but I think somebody who has a history of training, I mean, you can easily ask for somebody's CV or look up information about them. The advent of being online now, you can find out anything about anybody, basically. But I think that most of the people, especially psychologists and related people who are in this space, go to IOCDF meetings. They have a relationship with the IOCDF. They have training with them. They've presented multiple times. Liz, I know you've presented, I mean, I don't know how many times, it has to be hundreds of times, in terms of speeches, lectures, and things like that. And I think just looking for a track record of somebody who has that history and knowledge base of things. I mean, it's not to say that people who are starting off in the field also can't be supportive. They definitely can. A lot of interns, residents, postdocs, things like that, historically, who have worked very, very well and support a lot of people, as long as they're being supervised and being trained by somebody who has a historical knowledge base of this. And then, I was going to say also, it's very helpful. One of the questions that I can ask or have people ask is, do you have other patients who you've treated who I can speak to and meet and or talk to at all, about their experience and things like that? And I have a long history of different patients, and many of them, probably about a good dozen or a dozen and a half, will say, anytime you want somebody to talk to me about my history, what we've done, what we've worked on, I'm happy to. And I love connecting patients with one with another and having them talk just independently on their own about what they experienced and what they went through. And there's also tons of chat groups and things like that for the different programs throughout the whole country that you could find out like what did work, what didn't work for certain people as well.
100%. And I think, I think what you brought up is really important for us to just touch on for a second, which is the importance and value in specialty clinics. So in the OCD world, as we start to talk in a second about the few clinics that exist that offer higher levels of care, what I really want us to recognize is that most of us in the OCD world that are OCD specialists, meaning that's primarily what we do and what we focus on, we have usually always, I hope, had training at one of these specialty clinics or have trained under somebody who worked there, right? So what Dr. Spielman was saying that's really critical that we recognize is that oftentimes those of us that do outpatient OCD work, we started in a specialty program or got trained in one. So when we're talking about residents, interns, students, new individuals to the field, if somebody's brand new, they just graduated last year and they graduated college and they're just going and starting a private practice, they're probably not going to have the same background as somebody who maybe graduated a year or two ago, but even during their graduate school, they did their training at a McLean or at Rogers or at NBI or a specialty OCD program. Right now, we know they've kind of started to pave their career as an OCD specialist, and they've had that background. the key takeaway I always say, and we'll move on from assessment after this, is that if when you're looking for a provider and you Google their name, they say and have a list of disorders they treat, and it's about 20 or 30 disorders, and they're all over the place, from schizophrenia to OCD to borderline to eating disorders, you probably shouldn't go to them. And I don't mean that in a negative way. If you're wanting talk or supportive therapy, that might be useful, depending on what you're looking to address. But if you're looking to address OCD, you need somebody who's an OCD specialist. And most of us that are OCD specialists, we don't have the ability to do much else other than OCD, anxiety, and related disorders. Now, of course, that means there's a lot of illnesses that fall in that realm, right? If you, I did my postdoc at the VA, so, I have some background in PTSD and I have background in other anxiety disorders, and, but they're related and they fall within the anxiety realm or OCD realm. And that's about our capacity because we get so full. And I think that's really important. If you had to guess, Jason, what would you say your caseload is percentage-wise of OCD and anxiety?
I would say 90% or above.
Right.
And I think you want somebody who has a very high percentage. Also, I don't mean to, so I'm in South Florida right now, just as an aside, and there's a big storm coming in, so I'm hoping my power doesn't go out. But if it does, you know what happened.
Only the uncertainty. No worries. I hope you're okay. But yeah, but I think that's important, right? If when you see somebody, it's okay to ask, right? Like, what is your caseload? Like, how many patients do you see with OCD? And if someone says like, oh, I've treated 1 or 2 patients, they're not necessarily an OCD specialist, right? Those of us that are OCD specialists will say like an overwhelming majority of our caseload is OCD and anxiety. And that is what we specialize in, and that's where our background is. And I think that makes the world of a difference. And I always say this when I think about like cancer, right? If you had cancer, you'd want to be going to an oncologist who specializes in the type of cancer diagnosis you have versus going to a general practitioner or even an ER doctor who may not really know what type of treatments recommended for your diagnosis and for what's going on.
I think that's a good point. And also just on top of that, I think, I get different referrals for lots of different, people to work with. And like the example that you made, if I have somebody who's referred to me who has schizophrenia or has a drug addiction or has multiple of other things, it's not somebody I typically will work with. And I refer out usually, and I'm like, hey, this just isn't the right fit. So I think that the more specialized you are, the more you want to look for somebody who has that background. And I totally agree with that.
Yes. And I actually saw a couple questions or comments that I just wanted to touch base on. And it's really around the cost of OCD treatment. And I want to say one thing, which is that there is no doubt specialty care is more expensive. I also believe like you get what you pay for, in the sense that sometimes we hear people who've had 10 years of not great treatment and they've exhausted so much financial resources that if they had gone to an OCD specialist, they may have been able to get a lot more out of that funding. But what I want to reiterate, and you can actually find this article on iocdf.org, and Chelsea, hopefully you'll have time to be able to post it, but it's from Fred Pinzel, and it's a wonderful article that walks you through the steps of using your insurance to get reimbursement for out-of-network providers. Yep. So oftentimes, many of us, like myself, we may treat patients and we don't accept third-party payers, but we can provide what we call a super bill that then you can reimburse and file for reimbursement independently. And you actually will have really great success most of the time with reimbursing on your own, because you can justify that OCD requires specialty care and specialty treatment. And so there's wonderful articles to help walk you through that. And I just want to make sure people know that just because you see the cost of a provider and you think I can't afford that, that doesn't mean there's not options to still utilize your insurance.
I think on top of that, there's a couple of things. One is a lot of major facilities and providers will have some type of financial aid that they offer a lot of the time. I think it's just advocating for yourself when it comes to that. And as long as you go through the financial aid, like loops and hoops and things like that, that there's often a lot of flexibility with that. There are certain programs that take insurance directly. There are certain programs that, like you were saying, Liz, only take out-of-network benefits, but there is a lot of support that can be had if you really advocate for yourself. And there's also advocacy insurance support groups that will be able to help advocate for you. I've used multiple of them in the past, and they charge a small fee, a small percentage, but then they will advocate for you and be able to try to collect. And they know all the sort of nuances and things like that of the things to ask and to sort of say when they're trying to apply for things. So especially when it comes to intensive or hospitalization care, partial hospitalization, I think those are really important factors to consider.
Critical. Yeah. It's just so important. And I honestly, that was a new language for me, even in the past couple of years. I think I always assumed, oh, you're either a private pay clinic or you accept insurance. And I didn't realize that most of the private pays, majority of their patients are still using insurance. It just looks a little bit different.
Sure.
So let's jump into levels of care. So if you want, maybe you could just introduce kind of what traditional outpatient looks like, traditional IOP looks like, and then a higher level like a residential or inpatient.
Yeah, definitely. So I guess traditional outpatient would be the very traditional once a week. I see people traditionally once a week, sometimes 2 or 3, even 4 times a week, depending on severity, what we're working on, goals. A lot of the time we do is sometimes double sessions for an exposure base if we're trying to sort of sit through the curve of somebody sort of getting through an exposure and things like that. But I think the path after that is the consideration for an intensive outpatient program or an intensive treatment program, different sort of verbiage, where you go to somebody pretty consistently for 3 or more days a week. And it could be for half-day sessions or programs that we have. So a lot of the time, historically, I've worked and we've had people come in from either 8 or 9 in the morning until noon or 1 o'clock. Then you have a chunk of time that's like that 3 or 4 hour time where you have individual sessions, 1 or 2 group sessions, and different exposure activities that sort of are planned around that time. And I think that's for the person who is having a harder time, who's not really seeing success but the once or twice a week with working with an individual therapist, and who would really benefit from being able to be in more of like a group atmosphere or something like that. So having people around you, having individuals around you, groups are really helpful, supportive aspect to be able to work as a team and things like that with other people. And also a lot of the time you have different therapists that you can work with. So most IOP or ITP programs have more than one therapist that you can work with at a time in groups or other activities. And I always like to say that different mindsets actually really fuel different ways of looking at things and different sort of supportive tactics and abilities. And then the next obvious step would be a full program where it's a partial hospitalization program, a PHP level of care, or somebody who's in a residential program as well. And the residential programs can sort of go from many different aspects. So, one aspect is living in an off-site house, and there's a lot of different programs that are like that. That's the one probably I'm the most familiar with. And you would live in a house, you would stay there through the late afternoons, evenings, and you'd wake up and you'd have transportation to the facility that you would go to, and then you'd spend usually 8 or 9 in the morning until 4 or 5 in the afternoon, and you'd drive back. Usually the 8 in the morning until 5 in the afternoon, you have like a whole program of activities that's set up on a schedule for you, from individual therapy and group therapies, activities. A lot of the time you do meals together to work on OCD related to eating and eating conditions. A lot of the time there's executive functioning that's included in terms of how you organize things. There's usually very often an eating component, so a nutritionist or a dietitian plays a role. And then actually I think it's extremely important to have family involvement as long as the family is participating, because often when you go back to wherever you came from at some point, family is involved in terms of your relationships with them or loved ones or otherwise. And I think it's really important to have them participate. And then there's also the other programs where you're in a hospital or hospital-based program and you stay there and live there and the therapy happens there in a very similar type of fashion that I'm just describing. So I think it's important to be able to sort of pick and choose what makes sense given your level of severity, given your willingness to do things, and given sort of a family interaction as well.
100%. And I think what's critical and that you're hearing is that even in intensive OCD options, there's levels of care. So they really range from this kind of intensive outpatient, residential, and then inpatient settings. And one of the things that I think is really important we talk about, because it was brought up as a question in advance, is how do you know which intensive level of treatment you need? And how would you make a determination of like, I need IOP versus I need PHP or maybe even inpatient?
Sure. I think it's sort of hard for you to sometimes tell as an individual. I was just talking before, it's hard, like in a soccer game, to both be the coach, the player, and in the audience at the same time. And you typically don't do any of those very well if you're trying to do all three. And I think having a specific person that you trust in terms of one or two people, a clinician, a therapist, a family member, saying, hey, we're sort of noticing that this is the trend, this is what's going on, and being able to have an honest conversation about that. I think that a lot of the programs that we've mentioned, and especially a lot of the ones that the IOCDF sort of talks about, are very reputable, and they have very specific protocol and expectations of why somebody would come into that intensive program or hospitalization program. I don't think anybody's going to accept people if they don't really belong or sort of need to be there. I think from your own perspective is if you're working with somebody who's a therapist or you're a clinician right now, and they're saying, hey, I think we should take a look at this. This is something that I think you should strongly consider. Maybe trying to figure out why that is. How much is OCD really interfering with your life? If it's something that is starting to struggle or create struggle, for an hour or so, a day, a week, there's a different differentiation that we'd have. If you can't really function, if you can't go out of your house, well, right now is a little different time given COVID, but if you typically can't go out of your house, can't make food for yourself, can't socialize with people at all, can't maintain a job, there's a lot of things that OCD robs people of. And if you're spending many hours a day on a given day, being able to be stuck in the space of compulsions and obsessive thoughts, then it's something you should think about a lot more.
100%. And I think, one of the critical pieces too is, first and foremost, all of these places that do intensive OCD treatment that have, that are considered like a specialty OCD program have admissions and assessment coordinators. And their job is to do a really full, thorough assessment and intake to determine if it's appropriate fit. And they might say something like, yes, you're a fit. They might say something like, this is what we'd recommend. Or they may even say something like, we'd recommend this type of treatment first. So a lot of them, for example, a lot of the OCD programs may require a level of sobriety. And if you have an active addiction, they might recommend that addiction treatment happens first. If you have an active eating disorder, they're going to want medical stability prior to entering their program. So it really depends, but it's their job. And I think, as Dr. Spielman's saying, that's critical is your outpatient provider, if they specialize in OCD and they're giving a recommendation, again, they're giving you this recommendation based on the goal that you're going to be able to move forward in treatment, right? And it's our job to be able to say, you need more than what I can offer. And that leads us straight into a couple of questions. So I want us to we'll transition into a few questions that were posted and then make our way back. But why don't we start at the question, Chelsea, at 1214 from Bridget. She said, I'm asking for my son. He's struggling with intrusive negative thoughts and feels bad calling his therapist other than his weekly visit. And I'm curious to hear your thoughts on this, because we hear this a lot where individuals will say, I feel like I need more support, but I know I'm supposed to have this kind of healthy boundary. But what are your thoughts on, like, as a client, if you're feeling like I need more, or this like once a week, I'm feeling like in between, it's not enough. What do you recommend?
Well, first, Bridget, thank you for the question. That's a very cute picture, by the way, Bridget. So that's a great question. I think that you can hopefully be your own best advocate of knowing, like, hey, things are not going as they should, and I really need some more support. But I think we need to sort of be careful not to get stuck in a trap. And the trap a lot of the time is I need to continually seek reassurance from parents, loved ones, support providers, all that stuff in each and every time. I think one of the goals is being able to be taught and to learn some skills, especially when it comes to obsessions or intrusive thoughts, about how to be able to accept that those thoughts are going to be there, and how to be able to speak back to the thoughts, speak to yourself when they happen, and be able to respond to them. And not each and every time have to go seek the support of a therapist. The goal is for the therapist to help guide you in terms of how to respond when those happen, but to set specific times with the therapist, be it once a week, 3 times a week, whatever it might be, in terms of learning some skill sets of how to work on those things. So we want to be careful the balance of like the enabling part versus like advocating for yourself in terms of I need more therapy and support. But I think, Bridget, you're asking a great question in terms of how do I know what's really needed? If your son at that time is not able to function and is spending all day long, despite being able to learn some specific skills about intrusive thoughts, then yeah, it might be time for us to look at, hey, what are some other options? How can I increase the therapy that's being sort of provided at the time? And what would that look like in terms of that therapy? How much time is needed? And it really depends, like we said, like Liz was saying about the therapist provider and us doing a really good screening of what's going on.
Yeah, and I think what the point you brought up that's critical is really this balance as a patient, and I know what it feels like from a patient perspective of really seeking the help that you need and advocating for yourself if you feel like you need more and it's not enough, but also being able to have these boundaries that will be healthy. So I think for me, I really always had to, when I was younger and I was trying to learn what treatment looked like, I had to walk this balance of, okay, when do I know I need more, right? Like I'm not able to complete my homework. My OCD is becoming overwhelming in between sessions and I really need extra support to do my work versus when am I relying on my therapist too much, And the best best advice I ever got was, you have to learn to become your own provider. And I think it's this balance of, okay, when do I know I need it? And being okay and being willing to advocate for yourself and being comfortable with that. When I'm struggling, and I think to this day, if I have a, trigger and I'm really, really struggling and I need twice a week sessions, then I call and book twice a week sessions. There's no shame in that for me. That's me knowing what I need, but then also being able to know when I only need once a week or every other week and advocating for that as well. And balancing and trying to do the work on my own, because that's a critical piece in our recovery.
I think also just one thing, having a trusting relationship with the therapist that you're working with also, because I've had patients who I've said, I'm not seeing you later in this week because I know this is something you know what to do and I want you to work on this. And I said, you can email me like an update of what you did rather than us spending time and money and resources and all that stuff for a second time when it's something that's not really needed. And I said, I want to see what you can do, with this time that you have. So I think I totally agree with that, but I think it is a balancing of like, how do you respond and what you need versus what your therapist, who hopefully knows you very well, can be able to say, no, this is something that's probably needed for you and how to work on that.
100%. So we'll jump back to a question at 12:11 p.m. Chelsea from Laura. She said, what if you've been with a provider for a long time and you feel stuck with them? And I think this is a really important question for us to address is, how do you kind of know and make the call to say, like, this isn't working or I need to try something else?
I think that you have to be able to advocate for yourself and have a conversation with the therapist. Look, you're sharing lots of intimate details, information, conversations with the therapist you're working with, from all types of intrusive thoughts and urges, compulsions, all types of things. I think that one of the goals is being able to, share with them like, hey, these are the things that are working and these are the things that I'm a little concerned about that might not be working. And I think even make a list and say to them, hey, I want to touch back on some of the things that have gone very well, in my treatment so far, because it's a process that you're working with. A lot of the time where we sort of said in the beginning, it starts with OCD screening tests and, Y-box and things like that. But then being able to follow like a stepwise thing of how do we conceptualize what's going on? What types of core issues are really going on in terms of symptoms. So a lot of the time, something like contamination might not be a core issue. It might relate back to, I don't like things that feel disgusting or dirty, or a lot of different things. Being able to then acquire skills, it's the next step in that whole process, and being able to apply like the proper types of treatments, skills, and services in that. And then at some point, there's a level of like maintenance and follow-up that's really important. But like you said, Liz, sometimes the maintenance and follow-up is something that you meet with somebody on a weekly basis still, or every other week basis still, and that can sort of ebb and flow over time. But I think that if you're brave enough, I think, to be in treatment and therapy, that one of the other things that I would hopefully advocate is being able to be brave enough to sort of speak up for yourself and say, hey, I just want to touch base. This is something that I don't feel is going right, and I want to sort of see what you think. Could we get a second opinion? Do you work with other people? I'm just not sure if this is the right match right now, or what other things can you suggest? And I think it's very noble of a person to be able to do that.
100%. And I think, what I'll also say is that the more you understand and become, I guess, well-educated in OCD throughout time, the more you will also start to question whether or not someone's an appropriate fit if they're not. So, when I first got treatment and I was looking for OCD care and didn't even know what was going on, supportive treatment probably would have been decently helpful for me at the beginning, just because I was just understanding my condition and trying to understand family dynamics and stuff that was going on. But there would have been a point in time where I would have realized, okay, while the supportive therapy might have been helpful a little bit at the beginning, it's not improving my OCD. And so the real threshold I would always say is that if you're not seeing improvement from OCD symptoms in even as little as 6 sessions, you might want to start to wonder what's going on. Now, again, the more severe OCD you live with, it might take a little bit longer, but by session, even 2 or 3 for most of us, but let's just say 6 if you really had some other stuff to work through first. If you haven't really developed a hierarchy and you don't have a kind of a clear systematic approach for engagement in ERP, and you're not doing homework and you're not kind of doing these things that we're talking about are the tenets of our treatment, you may want to question the provider's expertise and whether or not they can move you forward with your OCD care. All right, so let's hop to 12:16 p.m. And I apologize, I'm probably not going to say your name correctly, but Ravi Pati, he said, from your experience, I'd like to know how long an individual can be free from OCD after ERP therapy. And I think that's a wonderful question.
It's a great question. It's a little bit of a loaded question because the concept of being free from OCD, I'm just not sure where that lies. OCD, I don't think to date is a curable disorder, but it is something that most people learn how to live with from treatment and from working on things. It's something that over time can be something that's much louder in terms of symptom severity, and you hear lots of stuff and you do lots of things. And sometimes a lot of the time with treatment, and the goal is that it sort of softens and that it's still there. You have OCD, but it doesn't typically go away. But I think that the question overall is how long can I expect for OCD maybe to be quieter and sort of softer over time? And then I think that really depends on how much effort and time you're going to spend in something. So if you're going to spend a lot of time working with your therapist and working especially homework-wise on your own and out of the office, then you have a much, much greater chance in terms of it being softer for a longer period of time. But I think it's so important for us to recognize that we need to be able to practice things afterwards. So if I want to get really good at practicing or learning how to play the piano, I could probably learn how to play a song within a few days or a week. But if I wait another month, I'm probably not going to learn or remember how to play that song very well, given that I don't have some unnatural ability to play the piano. I have to continue to practice that over time. But eventually, it's pretty cool. It's sort of like learning how to drive a car or ride a bicycle. In the beginning, you have to think about all the steps of how you pedal, or how you hold on, or how you shift the car, or putting the seatbelt on. But eventually it becomes almost second nature and automatic. You're oh, that's one of those OCD thoughts, or, oh, that's one of those compulsions that either I used to do, or, hey, that might be a new compulsion that I'm sort of starting to do. Let me think about that or research that a little bit and be able to learn, all right, how can I stop that? So the whole goal is, instead of the symptom severity getting huge, in a long period of time, as most people experience, it's, oh, I noticed that is a little bit of something that's starting. Let me now do a little bit of ERP or sort of reach out to a therapist or both and say, how can I squish that really quickly in the beginning so it doesn't become something huge? So I think that's one of our best things for us to be able to look at.
Yeah, and I think to answer the question from my perspective as well, I would just echo everything that Dr. Spielman's saying, which is that, I agree. I wouldn't say free from OCD either. I would say management of OCD. And I look at it much like exercise. I think when I used to run, I probably could go out and run 5 miles and not have any issues with it. Where guess what? I haven't run in multiple years. And if you told me I had to go run 5 miles, I really wouldn't be able to do it effectively or certainly efficiently. And so my run would be a walk, and a very slow walk with lots of breaks. And so the reality is that actually ERP can allow us, when you have the tools and to manage your OCD for the rest of your life. But the more you make it a part of your daily life and just a part of the way you live, the easier it will be for you to utilize those tools when you need them. I always, when we talk about deep breathing, and we talk about deep breathing when we're feeling overwhelmed and anxious, I always tell people the first time you learn deep breathing techniques and you want to practice them shouldn't be in the middle of a panic attack, right? You want to practice these skills and get good at them when you're calm and collected, and when you can practice them effectively so that when you are triggered, you can use them. And it's the same for ERP. And so if you kind of just take a big break and you stay out of it for 2 years and your symptoms continue to increase and increase, you might need a little bit more help jumping back in, but you can absolutely use ERP for the rest of your life to successfully manage OCD symptoms.
And I think one thing, Liz, to add on to what you're saying, it's not that like when you stop treatment, your symptoms the next day are going to explode again. It's
Right.
not that common. It's a very gradual rise and a very gradual fall. And I think it's something that you recognize. It's sort of almost like, weight management also, like you were saying before about running. You're not going to wake up tomorrow and be 100 pounds heavier, or in that mindset, 100 pounds lighter. It's something that you practice over amount of time. And as long as you allocate time for it, it's something that's really manageable if you choose to.
Yeah, I think most of us can relate to that analogy. I think for me, when I was going through like a weight loss journey a while ago, when you had this goal, it felt so hard to get there. But then once I got to my goal, for me, when I'm in maintenance, it's pretty easy, right? It doesn't mean you don't have to still watch your weight and make good decisions, but it's way different to be like, oh, I stay within the certain pound range and I feel good about it, or I need to lose 50 pounds, right? The treatment intensity differs, and it's the same for OCD. So let's hop to the question that is posted at 12:18 p.m. from Brett. They say, hi from New Jersey. Thanks for doing this. My son has been with an OCD therapist for 18 months, and she's amazing, but still having him go twice a week plus a parent session once a week. It's very expensive, and I was okay with that at the beginning, but I'd like him to meet with her only once a week. Any suggestions? And I think it'd be great for you to touch base on two things here, Dr. Spielman, which is like, where should you be after a year and a half with OCD treatment if you've been going twice a week and doing family sessions as well? And at what point should people, if things are going well and we're seeing that, at what point do you tailor down to traditional outpatient?
Sure. Yeah, definitely. I think that's an interesting question because everybody progresses at their own pace. I think that in terms of after 1 year, you should definitely have lots of knowledge base when it comes to education or, what you should do. You should understand CBT. You should definitely have a hierarchy that you've worked on. You should definitely have a lot of different goals that you're sort of working on over time. And I mean, it depends on the person altogether, but I think you should be in some level of aftercare depending on symptom severity and what you've been willing to do. Some people, and it really depends also how old this person is. Did it say?
No.
18 months they've been in therapy. So if it's a child, then it's a little bit different, I think. But if it's a young adult, I think one of the things also, probably actually even both, that we should have some type of family sessions where we sort of all meet together and talk about like where we're at, what the goals are. And at some point, the support from mom and dad has to be the pressure and sort of like driving force to say, hey, we've given you a lot of this to support. You know all these things and all the different skills, per your therapist and per yourself. Now we're looking for you to implement some of these things. And I think that's a hard decision a lot of the time for parents to sort of shift that model from a 100% supportive model to now we're going to hopefully have you independently work on things, be it from jobs or school or things like that. And I think that is a hard space to be in. Well, the second question you asked was?
So I guess for me, the question that I would wonder is I think first of all, what we want to both say is that just because you've been in treatment for 18 months doesn't mean OCD should be well managed. But I do think at that point, you should question if what you're doing is enough. Right. And so I'm not at all saying this person isn't an OCD specialist. They very well may be. But even myself as an OCD specialist, if I'm seeing someone twice a week and it's taken 18 months and they're not managing their symptoms well, then I probably need to be saying, hopefully before then, but I probably need to be saying like, do they need a higher level of care? Do they need more intensive treatment so that then they can taper back? Because I feel like it's pretty reasonable to expect that you'd be down to once a week within that time frame. And if not, maybe that means the level of care wasn't or isn't appropriate. Do you agree with that?
Yeah, very much so. And I think being able to look at that even way more than once every 18 months is really important. I would look at that every, month or two or three to say, hey, where are we at right now? What are we specifically working on? What are the goals and what are the expectations with this? There's no crystal ball to say tomorrow, next week, next month that things are going to be sort of in a very different space. But I think that having a plan of how to do that is really important. But just in like unlimited time that we work on this is also something that's not reasonable to sort of expect also.
100%. So I'm not going to attempt to say your name, so I'll say Mr. Rajan at 1218. So you've talked a little bit about being in India and seeing a psychiatrist, but not doing therapy yet. And so you said at 1218, they haven't recommended any therapy. What should I do? Not sure which form of OCD I have. It's pure. My intrusive thoughts are all about one form and pattern. So what I will say is that, again, this is where we would both recommend a really thorough evaluation. And if you have received a diagnosis of OCD, you absolutely want to be in therapy and you want to be engaging in exposure with response prevention. Sometimes we have to do self-help to be able to have access to it depending on where we live, or we can go into these options we've talked about of outpatient, intensive outpatient, or higher levels of care. And so what I would say, and just want to reiterate, is that if anybody has a diagnosis of OCD, oftentimes medication alone is not the treatment we would recommend. The gold standard always is a combination of medication and exposure response prevention. Mm-hmm. So moving into Erica's question at 1225, I've done therapy for 5 years. I don't think my OCD is better. I think I've just given up. Disassociated, my brain just turns off now. Is there a way to tell a difference?
I would want to know what difference she's looking for. What is that? I'm not sure entirely what that means. Is there a way to tell the difference? But I think she means, is there a way to tell the difference between my OCD and like sort of my real life of what's going on? But I think like Liz was just saying, I know Erica, you said that for 5 years you've been in therapy. I'm not sure if you've been in any intensive therapy or any residential or hospitalization type of care. It might be something to consider. And also, I'm not sure how much medication management has been sort of as part of the routine that you've had, but I obviously would consider both of them as well.
Perfect. Totally agree. And so Marlene at 1227 said, does the Denver area have any place where there's outpatient therapy? Absolutely. So there are outpatient providers in Denver that have OCD training and background. I would encourage you to visit iocdf.org and put in your zip code so that you can make some selections. If you need peace of mind to help you, we'd be happy to help with that process as well. Thomas, couldn't agree more. You said, I've started getting help in 2015. Nowadays, I do only go in if I feel I need to. The OCD doesn't ever go away, but eventually you hit a point where you trust yourself to be able to help yourself in your own way. And I think that's so beautifully said and just so critical.
It's so well spoken. And I think one of the best things is every person who's working on OCD treatment is becoming like their own sort of self-advocate, being able to say, I recognize this. As long as you take like the time to be able to work on it, it's like choosing the path of, I'm going to sort of allocate time to work on this specific thing that I know that I have as an issue.
Couldn't agree more. At 1229, they said, my therapist does not want to try ACT or mindfulness. We've been doing ERP for roughly 9 weeks, and my Y box has changed minimally. What should I say? I feel like I don't know what to do with my thoughts.
I would say that I would want to be able to see if there's somebody else that I can get support with also from, ERP and ACT at the same time. I think that ACT is a really important sort of type of CBT process that you work with people who have a lot of obsessive thoughts. And I think strictly ERP with more tangible things would be very difficult with thought, with obsessions that you have. I think being able to work with ACT is really helpful for people a lot of the time. And I think it's part of the puzzle when it comes to CBT, including exposures.
Yeah, and what I'll also say to that, just because I'm such like a core behavioralist, right? Like ERP is a lot of what I do and speak about, is that most of us do utilize, or ACT is often actually incorporated into the kind of the basis of ERP. And so I would also wonder if there's a reason that your clinician is wanting to just focus on ERP first. And sometimes that may clinically make sense that maybe we would conceptualize it differently. However, at the same time, what I want to say is that you should know what to do with your thoughts. So if you are doing ERP only, you should have a clear understanding of how you handle your thoughts and what you should be doing when intrusive thoughts come on so that you don't reinforce them. And so I would wonder, I would encourage you to make sure you get answers to that. 9 weeks is a rough time point, right? You're already seeing a decrease in the Y box, which is excellent, but at the same time, you may need a little bit more time to know. So I think it depends on your rapport, but also again, I think the common thread here that Jason's spoken about today is being able to communicate that with your provider of like, hey, I really would like to incorporate ACT and or mindfulness. And like, I think that would be valuable and important to me. So can we talk about it? So at 12:29, Shannon said, my daughter needs more help. Her rituals are taking over her life. Are there any programs that you recommend for children? We're willing to travel, but we live in Virginia. So I'll start and then let you add on, Jason, but there are absolutely programs for children. It depends what you're looking for. The McLean OCD Institute does have a child residential program that is kind of being updated and moved to the main campus of McLean. So that's outside of Boston in Massachusetts. Our program in Houston, which is the McLean OCD Institute of Houston, we do intensive treatment with children, but we don't have a residential program. So the parents will travel, stay with the children, and then the children will attend kind of one-to-one intensive care with our behavioral therapist. And then Jason, I know NBI and lots of others offer some children aspects as well.
Yeah, Neurobehavioral Institute in South Florida in Weston, where I used to work, has a wonderful child program as well as many other options. And people often fly in and stay at a local residence or hotel, and they have an intensive program. Also, where I am, also the Anxiety and OCD Treatment Center of Florida, we do intensive programs also for people, usually 3 days to 4 days a week as needed. But there's a lot of programs. I mean, in Rogers, they do a treatment program for kids on an IOP basis. And I think the best resource is the IOCDF's support page, where they list all the different programs. And it's great, Shannon, that you're willing to travel. I think a lot of the time, being more flexible with where you go, you'll probably get the most support, being able to have the option of different programs to go to.
Yeah, and I think, the beauty of the IOCDF page is that you can call and get a feel, and usually when you call programs and you visit their websites, you will be drawn to a couple more than others, and or for different reasons, you might rule some out and rule some in. And so really take the time to explore. Don't go with the first person you call. Spend some time really researching and thinking about what is the right fit for us and our family, and where do I think we would benefit the most from the programming that they offer. So, Erica, I see that you kind of answered Jason's first part of his question about knowing more, but what I'll say is I always want to be cautious that we don't go too much into specific treatment and therapy for individuals. And so I would encourage you to really find an OCD specialist and or even somebody who can provide a full assessment so that they can know the full story and the full picture. That's critical for all of us first. But once you know it's OCD and you're working with an OCD specialist, they should be able to help provide an appropriate treatment plan so that you can gain control. I think it's really critical that we know if it's OCD and we're with an OCD specialist, we should see benefit and we should start to get better. And if we find that we're not getting better and it makes us kind of lose hope in the treatment process, don't let that stop you from trying again and trying with someone else. And additionally, sometimes there might be something else going on as well that we need to think about and address, right? A lot of us with OCD might also have other comorbid conditions that sometimes when we recognize that exists, and now all of a sudden when we utilize ACT or other treatments that would work for that, we see even better benefits and even better outcomes than just ERP if OCD alone might not be the only thing. And so I just want to say that overall, depending on what anyone's going through, make sure that you're with a specialist for whatever's going on and that you're really advocating for your care, because you should see yourself moving forward if you're in appropriate treatment. And there is appropriate treatment for any diagnosis overall. Shannon, we won't go into medication because we're not medical doctors. And so on these talks, we'll always encourage you to see an OCD specialist who's a psychiatrist. And I think that's new language for a lot of people. A lot of times we don't even realize that there are psychiatrists who specialize in OCD, but there really are. And I think that's really critical to make sure that you're gaining access to. And sorry, Jason, I know you had other feedback as well.
No, I totally agree with you. And I actually work with maybe a handful of psychiatrists nationwide, depending on where they are, that I refer to people specifically because I know they have expertise. they're on the IOCDF board, or different things that they have a knowledge base. I just want to make sure we have time to get to one question by Anna, which it looks like you might go to next.
Yes. So my daughter is homebound, and it's really difficult to convince her to see a doctor. What do you recommend? At one point, she was on medication, noticed it wasn't helping, and has lost hope.
I think this is a great question, and I love to be able to answer this because it's really, really common. We've been talking a lot about throughout this whole conversation about a lot of the people who are willing and motivated and they want to do things and they want to be in treatment. But what do you do, as Anna's pointed out, when you have somebody who's at home and they're stuck and they don't want to talk to you and they don't want to be in treatment and they just want to sort of be supported and they want you to sort of enable? And a lot of the time we've seen a lot of cases where it gets very even like almost aggressive and sort of arguing and yelling and screaming. And I think that one of the best cases with this is really to say that we would have parents at the first point become patients. So we would have the parents come into treatment, either sometimes traveling throughout the country and flying in and being in intensive treatment, or virtually, that we have people start to work as a family and parents to start to recognize a lot of the signs, symptoms, and ways that they're enabling, and being able to sort of stop those and change those patterns that people have and that people do for other people. So the more stereotypical of I have to clean and wash, a lot of the goals then would be stop enabling, buying soap and engaging and all the rituals that go along with that. But I think giving parents and family members a lot of education, psychoeducation about what to do and what not to do is extremely important. And we've worked with a lot of patients who their family just start for the first week or 2 or 3. And we eventually sort of gain, I think, the family's trust with being able to have the young adult or child or otherwise be able to come in and participate. A lot of the time also, if somebody refuses, there's a lot of other things that can be done. If it's in a local area, I've gone to people's houses a lot of the time. And so it's really important to be able to have a practice or some type of space that people can go to do home sessions. A lot of the time things happen in homes. I've done sessions in homes, in stores, in malls, in cars, all over the place, really. So having a flexible provider, I think, is a really important thing. And now, especially in today's time, with the advent of everything being on telehealth and teletherapy, it's actually sort of more convenient to a certain extent, and you get to really see the home environment. But I think working with the families and parents is really, really important, and changing the dynamic at home. A lot of the time we base all these things on the home family values, and I talk a lot about the values of a house and what values parents are looking at and what values the patients are looking at in this context. And if we're moving toward those values or away from them, in my mindset, is a really important thing.
100%. And I think I'll speak on as an advocate on behalf of my mom. The one thing my mom always says is that she's so grateful that I was a minor when she was first searching for treatment, because she could require me to go. And, I actually talk about this a lot with parents who are struggling with, well, should I require it? Should I? And my response is that as a child, we don't know what's in our best interest, right? We usually don't have the insight to be able to say oh, this is going to be hard, but I need to see an OCD specialist. That's often our parents advocating for us. And it's important to remember that once we're 18, you really can't make us go anymore. And so I always say, if you're worried and there's clear symptoms that need to be addressed as a minor, I would actually make it a requirement, because you can at that time, especially if you can find an OCD specialist. But then again, when they're with an OCD specialist, at that point, it's about creating a supportive situation environment at home where you're going to appropriately support them and move them forward. And I remember my mom's response to my provider was always, I want to be Liz's mom, not her therapist. That's your job. And it was great, because really we were able to have family sessions and come up with clear boundaries and roles. But at the same time, my mom could be the figure she wanted to be in my life, which was my mom, who loved me and cared for me. But at the same time, she had to learn tools also, because oftentimes loving and caring for a kid can mean enabling them if you don't know what you might be doing that could be encouraging their symptoms. So it's just critical that we always kind of navigate all these different things that come into play. And what's most important for us to remember is that each case, each of your children are individuals. And so their care should be individualized. There's no black and white, just standard treatment that everybody gets. We all need different things, and we all respond to different things. And what you've heard us saying over and over, and I'll let Jason wrap up today's little webinar, is that you have to advocate for yourself and what you believe you need. And as the individual with OCD, we usually know if treatment's not working. We usually know if we need more. We usually know if we need less and it's time to taper down. And it's our job to advocate for ourselves. And for those of you that are parents of a minor, you take that advocate role. And so it's just important for us to remember treatment's fluid, treatment changes, just like we're dealing with this with coronavirus, right? Every day something's different that can happen with OCD. And so you become flexible and you make the best decisions for your own care. Dr. Spielman, I'll let you kind of share any final words, tips, or advice that you have, but thank you so much for coming on today. And if you can make sure that you share how people can find you if they want to reach out to you.
Of course. So first, thank you so much to Liz and to the Peace of Mind Foundation. It's been wonderful. I love being able to talk and be able to share and help anybody, really. And thank you so much to the IOCDF for everything that they do to support everybody and the time that they spend to help organize everything to support people throughout the whole world. It's really wonderful. I would love to sort of wrap up with the concept of I would love to encourage everybody who's sort of there and out there, who's looking for support and looking for help, who is right now either afraid to do so or scared of what the next steps would be, to definitely work on taking that next step, being brave and advocating for yourself. And it could be scary, but definitely reach out to somebody for help. I'm always happy to help point somebody in a direction and give support all over the place. Peace of Mind Foundation has tons of support that they can offer in terms of direction you can go. But definitely get help. It's so prevalent right now, the support that's out there right now that people can get. And I'd really encourage people to do that. Myself, obviously, you can reach me on Facebook, which is at Anxiety OCD Florida, or anxietyocdflorida.com is the website. And thank you for putting that up there. And I'm so excited to be able to talk and spend time with you this afternoon. And thank you for having me on.
It's our pleasure. We are grateful for you, grateful for your time, your expertise, and your knowledge. And I know that the community certainly is. As we wrap up, I'll end with my statement I always end with, which is that help and hope are always available. And I mean that from the bottom of my heart. I know what it's like to be in a place where you don't think there's a way out. You don't think you'll ever be able to live a life where you manage your illness. But I also know that with appropriate treatment, that is absolutely possible for every single one of you. So reach out, get support, and ask for help, because that's our first step to recovery. Thank you so much. We love you all, and we'll see you guys soon.
Thank you.
Thank you.